I have found my voice in public health, and it's one of those areas I think for physicians to be able to have a voice that can be heard and have it heard across government.
Dr. Philip Chan, eShadowing session. I forget nowadays. I always forget to check. How you doing tonight, my friend?
I'm doing well. How about yourself?
I'm doing well. I love your headset. We're headset buddies tonight. But I think you have more of a radio voice than me. You got a nice, deep radio voice there.
Well, thank you. Thank you for having me. I'm going to have to disagree with you. I love your voice. You sound great.
Oh, okay. All right. Enough back patting. I'm excited to chat with you and the 950 so students that are live with us tonight about COVID, because that's all infectious disease doctors do these days. But we'll expand beyond that. Your specialty is HIV and STIs. How does one go through life, go through medical school, and go, I want to study HIV and sexually transmitted infections? How did you get to this point?
Yeah, great question. So I think a lot of people are drawn to infectious diseases because of HIV, and that's where I was. I love HIV. It's at the intersection of social determinants of health and research and public health, and that's what initially got me hooked. And then as I sort of got in the door of HIV, I was sort of introduced to all this other wonderful world of STIs. And only an infectious disease doc could say that. And so, everything's divided now, right, between pre-COVID and post-COVID life. And I think pre-COVID, all HIV, STIs, and post-COVID, one thing I was doing for the last 6 years was working with the Rhode Island Department of Health, consulting on statewide initiatives for HIV, STIs. And then, of course, with COVID-19, it's all hands on deck, like not just infectious disease docs, but healthcare workers in general. So I've literally, for the last 9 months, it's like 80 hours a week, COVID-19, that's all.
Yeah. Do you think from the infectious disease world, is something like COVID, is that exciting for you and exciting for the broader kind of infectious disease world, where it's like a once in a lifetime opportunity to live through this and to have all this new research coming in and exploring? Obviously, right, it doesn't need to be said, COVID sucks, and it's a huge impact on everyone's life. I've lost one loved one that I know of from COVID. But beyond that, right, looking at the scientific world, is it exciting?
So I think to your point, it's exciting, it's tiresome, it's crazy, it's, all wrapped up into one, right? So I'm exhausted, and I think similar to a lot of healthcare workers, I am just exhausted, and I'm ready for this to be over. But as an infectious disease doc, to your point, right? This is one of the reasons I became an infectious disease doc. How many pandemics have you seen before, right? Zero. Yeah. And hopefully not again. But if we do, we're well prepared at this point. Yeah. But it's been the experience of a lifetime, to be honest, academically, but one that I hope, it's going to be over tomorrow.
Yeah. What does a typical day in the life look like for you?
So I think one thing just for your listeners, I'm kind of a late bloomer, to be honest, to public health. As a practicing clinical physician, I got involved in public health late, meaning after I was out of fellowship. But I encourage those of you who are really interested in public health, in policy and making impact. It's been amazing. My days at the moment, I actually stepped away in September from doing clinical care because I just couldn't do everything. So I'm taking a few-month break from clinical care, and I'm pretty much working most of the time at the Department of Health. So I have meetings all day. I'm running sort of programs and talking about logistics and policy. For example, big things here in Rhode Island. We're in our second surge. We're discussing, when to. We had a modified shutdown over the last couple of weeks, and we're deciding when to lift that. CDC also released an update on their quarantine and isolation guidance. So we're talking about how we should implement that on a statewide level. We're talking about testing, right? Testing, what's testing, where do we test, looking at underserved populations, where do we test in school systems? What does that look like for next year? So, and of course, the biggest thing, right, is next week. What happens next week? Vaccines. So I'm told that vaccines will be here in a week's time. So vaccine implementation. And what I've learned, and this is, they don't teach you any of this in medical school, but in public health, it's like, the science of vaccines And what I've really enjoyed about public health is, well, how do you get vaccines out to the masses? Like if you think about it, with all these cold chain issues, -70 deep freezers, who's going to vaccinate? How do you maintain the cold chains? And all these questions that come up. So again, it's been an incredible professional experience to me. And for those of you interested even a little bit in public health, check it out, make a difference. It's awesome.
Yeah, I think I had a little bit of experience in the public health world and a little bit of pandemic planning in my time in the Air Force I was the public health emergency officer. So I was in charge of all of the planning for chemical attacks, bacterial weapon attacks. That's not the right word.
Bioterrorism?
Bioterrorism stuff. Yeah. And so we would work through these exact scenarios and go, okay, like, are we going door to door to give vaccines? Are we setting up one big shop and everybody has to drive to us to set up these vaccines? Like, it's really fun to think through this kind of stuff. I never thought we'd actually have to actually implement this kind of stuff, but it's interesting that we have bright minds like yourself working on all of this. Now, it's interesting, right? We have this pandemic. We have so much technology now that we have hopefully come to together, institutions working together, or is it just more of the same? It all comes down to the dollar and people are going to do what's best for their bottom line.
So I've been amazed about a couple things. I have differing opinions on this. So being in the Department of Health for 6 years, what's been amazing in our state, and I think a lot of states, is that the entire state has come together with Moderna and Pfizer, the first ones to market, and they stand to make, right, millions, if not, tens of millions of dollars. So it's all good. It intersects public health, but there certainly is a financial component to it.
Yeah, definitely. So let's talk about
practitioners, whether they be internal medicine, pediatrics, surgeons. I think one of the important things is just about HIV. So let's start with HIV, for example. It's really important to screen people for HIV. So no matter what, CDC, medical organization, United States Preventive Task Force, et cetera, they all recommend routine screening for HIV. The test costs like $1 or less because it's on all these high throughput systems. So again, everyone should be screened for HIV here in the US, and certainly populations that are sure, at least in our state, is that people, there's a 60-year-old gentleman comes in, has weight loss, has some chills at night. And what do you first think, right? You're thinking cancer, right? So 60-year-old with a lot of, non-specific symptoms. And we see these people and they get pan scanned with CTs, they get colonoscopies, they get endoscopies, they have like a, several $100,000 workup, and it turns out it's HIV and no one took a good sexual history. So a lot of what being an infectious disease doctor is just taking a sexual history, and, a dollar test, right, could have saved a couple $100,000 of invasive sort of, radiation and other interventions. So just something to keep, for people to keep in mind.
Yeah, very interesting. I'd love to jump in, invite some students to join us and potentially talk about some cases with you. One of the questions I love asking is bread and butter. What is some bread and butter stuff in the HIV STI world?
Yeah, so for HIV, I deal a lot with preventative care. So that may be something some of your listeners may be able to relate to. So I do a lot with pre-exposure prophylaxis, PrEP. There's also post-exposure prophylaxis, PEP. And then STIs, one of the most common, there's two general ways I think about STIs, right? You come in with a discharge, you come in with a rash, and those are really some classic presentations, at least, of STIs.
Yeah. What does the training path look like to become an infectious disease specialist?
Yeah, so good question. So it's a subspecialty off internal medicine. So I did 3 years of internal medicine and then 2 years of infectious diseases training. It's interesting. I think a lot of academic training programs involve HIV care. A lot of academic medical centers include HIV. I didn't get a lot of training through residency and fellowship in STIs, and it's something that I really had to seek out some mentorship through something sponsored by the CDC. So there's some of these STD training programs throughout the U.S. STIs is largely an outpatient sort of type of specialty. And that's not something you get on the inpatient side, and especially in some of the academic programs. You just don't get as much of it. So I had to really go out and search for STIs. And thinking about, HIV is an STI, But in the U.S. and a lot of programs, it's really HIV tends to be a little bit separate because it tends to be big, a lot of morbidity, mortality, and STIs. It's usually HIV and then other STIs. And these other STIs are such a diverse set of diseases and infections, et cetera. They're really fascinating and really common. In fact, much more common than HIV.
Yeah. And how many years of fellowship training is it?
2 years.
2 years of fellowship training for infectious disease. Is there more training to be an HIV STI specialist, or is that all kind of encompassing and there's no extra training after that?
It's all encompassing, and you really become a specialist where you spend your time. And for me, what I certainly post fellowship, during fellowship, I did some HIV research. Post fellowship, I actually started an STI clinic. I started the only state-funded STI clinic here in Rhode Island. So I gained that specialty knowledge over time, and I sought out some mentors like Kathy Hsu in Massachusetts, Mass General, BU, et cetera. So some experts from these different institutions.
Nice. All right, I'm going to accept if you want to come on, and we're going to go over some cases here with Dr. Chan. If you want to come on and be pimped a little bit, well, it'll be like going on rounds at the hospital. Come on. There was a where was I on? It was a TikTok that had a really good, like it was a real rounding. The physician, I think it was a surgeon, was asking questions to the residents, and it was brutal. I'm like, I had PTSD. I'm like, no, I don't want to be back there. But it was pretty funny.
So I'd like to maybe choose the first topic if there's anyone that wants to come on and chat. And again, there's no wrong answers. I'm usually pretty easygoing, but one thing that I do actually do a lot of, and especially research, is PrEP. So if people have any questions about HIV pre-exposure prophylaxis, please do come on and chat, and we can have a good discussion. I can tell you where we're at and cutting edge, et cetera. So, but happy to chat about anything.
Yeah, well, we got Smit on with us. You can turn your camera on if you want, or we should be able to hear you. Hello there. Oh, he's a Razorback fan. I don't know if that's okay.
It has to be. The Razorbacks are starting to do better now.
That's all right.
We got a new code.
So PrEP. Smit, what do you know about PrEP?
I was actually reading about Dr. Chan before, but I know that he started the clinic, but I don't really know the intricacies of what PrEP is.
Yeah, so good question. So PrEP is pre-exposure prophylaxis, right? So it's a medicine you take before you're ever exposed. And in this case, HIV. There's other medications you could take as pre-exposure prophylaxis, and that's why I sort of qualify it with HIV. But it's a pill a day to prevent HIV. The medications is specifically called tenofovir emtricitabine, and it works. It's up to 99% effective. And what we're looking to do here in the U.S. is to get it to people that are most at risk of HIV. And so unfortunately, 60 or 70% of the country's new HIV diagnoses are among gay and bisexual men. That's a population that we've really been pushing it out to and messaging and educating.
Nice.
Yeah. But I got to tell you, for those of you out there, you asked about this, so I'm going to go off just for 30 seconds here. One of the greatest experiences of my life actually was right out of fellowship. I essentially started an STI clinic. I just want to encourage you, for those of you that are interested in public health and policy and social determinants of health, I really built my career out of this STI clinic to some extent. And it started as community-based HIV testing. We brought it into the clinic, and I eventually got funding, and it really took off and has become the premier safety net in our state. So an example of just, finding the need, finding the gaps in your community, and just, anything is possible. Anything is possible. So that was one of the greatest professional experiences of my life.
So, Philip, I got an interesting question in the comments here that made me think. With PrEP, do we have any data potentially of any negative consequences of PrEP where people see how effective it is in terms of HIV, but it's potentially increasing other STIs because people are taking less caution?
That is a wonderful question. Thank you, whoever asked that. The way to look at this, the way that I approach infectious disease and public health is a bit of harm reduction, right? So if you look at the studies and you look at the literature, you're absolutely right, right? There's evidence that people who are taking PrEP use condoms less. And I think we have to ask ourselves, these people are being protected against HIV. So what are you got to look at both sides of the equation here. So there is some evidence that people on PrEP do have higher rates of other STIs. And that begs the question, how do we start to address other STIs? But I think it would be unethical for me ever, right, to withhold HIV PrEP from someone. And I think that we just have to have that honest discussion. And one question, just for yourself, right, just as we're thinking about these topics, I mean, I'm guessing most people on this call are in their 20s or 30s. When you went to the doctor, were you offered an STI test at your last provider visit? My guess is at least 50% of you may not have, And the other question, too, is how many of your doctors or physicians or other providers are aware about PrEP? My guess is there may be a percentage that aren't. So I think we still have a long way to go here with addressing sexual health and STIs and PrEP, certainly in our provider community here in the U.S.
Yeah, great. Kayla, do you have any questions?
Hi, I'm super interested in infectious disease and things like that. And we have been talking about in my microbiology class about antibiotic resistant drugs or not drugs, bacteria. And I was wondering what you see with the field of infectious disease as more cases of antibiotic resistant bacteria come up and how the treatment methods for those diseases will evolve.
Yeah, it's a great question. Thank you. I think at the end of the day, it's interesting if you think about some of the reasons that we don't have great antibiotics. And if you think about the motivation, just take a step back for a second. If you were a drug company, would you want to develop a new antibiotic? And the answer is it's not as lucrative as having to take a blood pressure med every day, right? If you think about an antibiotic for a sec, you're on it for like 5 days, 10 days, maybe 2 weeks. But it does not pale in comparison, right, to taking, a blood pressure med every day. So there's not a huge financial incentive for companies to develop antibiotics, and that's exactly what we see. So we're even going to like some of these old drugs like colistin, right, like some of these like weird old drugs that like no one has heard of or wants to hear of and have terrible side effects. And why are we still using amphotericin, right? I mean, come on, really? So it's like we need better drugs. We need to incentivize, but it is a huge problem. The pseudo good news is that most people who develop these are not younger people, right? So it's usually a disease of people who are in and out of facilities, huge problem in that population. But these hospitals are sort of breeding grounds for resistance in a lot of cases, just by nature of what they do. So big problem. It's been identified by the CDC as a major threat. And we do need more research and more development of antibiotics, especially. Good question.
What are some of the biggest kind of fronts in the ID world? In the oncology world, we have very directed therapies now based on genetics. Do you think we'll get to a very kind of gene-directed therapy in the future for infectious disease?
Yeah, it's a great question. So to your question about what's hot in ID, COVID's hot. That's the only thing that's hot at the moment. But in general, of course, to your point, yes. So I think a lot of what comes down with IDs, ID is the time to treatment. So I think that what's been impressive to me is about the diagnostics, the acute nature of the diagnostics, right? So we want to identify up front what the bug is, what it's sensitive to or not, or if it's resistant, and be able to get those antibiotics on right away and identify the pathogen. So I think to me, sort of some of these point of care tests will eventually become really standard in ID. And then the second thing too is, there's lots of infections that we just don't know, like what they're caused from, right? You have an abscess and nothing ever grows out. Like nothing ever grows out. It's like 50-50 lately. So I think there's a place for diagnostics in terms of either next generation or whole genome, and there's already, ribosomal sequencing, et cetera. But there's a place to do some of these more deep sequencing to understand what bug it may be or combination of bugs. So that to me is sort of the diagnostic future of ID.
Yeah, it's interesting, right? The fact that we have this kind of world where we do blood cultures, right, for infectious disease, and we wait and wait and wait for something to grow. Why don't we PCR everything?
That's a great point. Why don't we? That's where we're going to. We do it with SARS-CoV-2.
Yeah.
I agree. No one wants to wait 5 days for a blood culture, right?
Nobody does,
I'm
including
curious. Do people even do gram stains anymore? Do you all even learn about gram stains in school?
Yeah.
Okay. Well, I guess maybe I'm not that old yet. Someday you'll be asking the same question to your students, and they'll be like, "What's a gram stain?"
It's because it's the 80-year-old guys still teaching the classes. No,
That's true.
Part of the problem. Why don't we work through a little bit of a case that we can ask these students some questions?
Yeah, so let's say you have a young person that shows up and they have, let's call it a 25-year-old male shows up and tells you they have a little bit of a pain when they pee and a little bit of a discharge from their penis. What do you want to ask them? What do you want to do?
How long have you had this?
2 days ago.
Anna, chime in.
So I actually work at a Ryan White healthcare center right now. I'm as a scribe, so this is a fairly common encounter.
Well, now I'm going to throw you a twist.
Never tell the that you're like, oh, I just studied this. What are your thoughts? What do you want to know?
I guess I would be interested in recent sexual encounters, but also there's things like yeast infections that can also happen that could be kind of similar in symptomology with that. So that would probably be another thing I'd think about.
Let me ask you this. How do they teach you when you think about taking a sexual history? How do you run through that? What are they teaching in school nowadays? Where do you start?
Well, I'm not in med school yet. Fingers crossed, class of 2025. But
good luck.
Anyhow, I think that you want to not seem like you're really accusing the patient and be clear that this is really just to best treat them and to make sure that you're able to offer the best care possible for them, and it's not a judgmental situation or anything like that. We just really need to understand what's going on in order to best treat them.
Yeah, and I just want to say a couple things about that. So one thing that's important, right, is that both sexual orientation and gender exist across the spectrum. And I think, all of us have a little bit of bias and other things. And really at the end of the day, to treat our patients best, we got to check that at the door, right? So I was just a note about me. I actually grew up really conservative Baptist. So I was, there's no sex until, marriage when you're 45, right? So I changed and learned and, got educated in college. But, we all have some bias and stigma and other stuff, and it's just normal part of human behavior. But we really got to check that. So in thinking about that, as you engage people, asking about pronouns, that's sort of the world in which we live. Pronouns, not assuming that people have the sexual genitalia, right, that you may assume based on how they present. So just asking some basic questions about, so what gender do you identify as? What pronouns do you like to use? Your sex partners, do they tend to be men, women, both? How many have you had in the past few months? Things like that. So just, and the other thing I've learned about a sexual history, right, is the patient is only going to be as uncomfortable as you are.
Right.
Meaning that if you are uncomfortable, they're going to be uncomfortable, right? And so if you've ever gone to therapy, hopefully not too many people have, but if you've ever gone to therapy, one of the things that they teach, right, is to be curious, right? Be curious about everything. That's one of the fundamental components about counseling. So instead of being judgmental, you just want to be curious. Oh, tell me about it. And it's okay to admit that you don't know. Who the best educators for me and where I get all my great research ideas and where I learn pretty much everything besides up to date is from my patients, right? So just understanding, there's such a wealth of information. You just have to listen to them and understand. And especially in sexual health, right? A lot of us, I never learned how to take a sexual history in med school. I won't tell you where I went. You can probably look it up if you really want to know. But I never learned how to take a sexual history in med school or residency. I I had to learn it as I went, et cetera. So just be comfortable, be curious, have a basic set of opening questions, and mine are, your sex partners. Do they tend to be men, women, or both? How many partners do you have you had in the past? Doesn't even matter what time frame, month. Do you tend to use condoms? Tell me about your symptoms, etc. So that's usually how I start it. So good job. Yep, just a couple tips out there.
Very cool.
Thank you.
Good job. When it comes to that comfort level, right, especially if that kind of stuff isn't covered in medical school, how does one become comfortable talking about these things that we're not supposed to talk about with other people?
Yeah, great question. I think a lot of life, it comes down to finding a mentor and just volunteering and starting slow and shadowing. And I think similar to a lot of you, I just started shadowing and learning and doing it. And, I've made a lot of mistakes along the way, of course. But that's what we do is we learn, we move on, we get better. And that's what I did. So, and read, right? So if you Google, CDC, how to take a sexual history, you're going to get the 5 Ps of how to do that. And each P stands for something. So there's little tips and tricks, follow clinical guidelines if you're ever unsure. Besides looking it up and up to date, you can always Google, CDC website, look it up in a textbook if people even use those anymore. So there's lots of resources out there. You just got to read and learn and listen to your patients.
Nice. Kayla, Anna, Smith, any other questions before I kick you off here?
I have a quick question.
Yeah.
Or maybe it's not a quick question, but it's a question. So like I said, I'm working in a clinic where we see about 50% of our patients are HIV positive. And we always have this list of questions about their adherence to their drug regimen that they're on. And it's really interesting to me, how quickly we see viral loads creep back up and CD4 counts drop back down. And I guess that's kind of just wondering how quickly can that actually happen? I get to see it between 3-month follow-ups or something like that. But really, how many doses is it or something like that to really see a big difference between going from undetectable to suddenly having a viral load?
Yeah, you mean when someone's actually on meds and suppressed?
Mm-hmm.
Yeah, so it actually depends. If you look at the studies, it's a whole spectrum. Some people actually stay undetectable after being on ARVs. You can stay undetectable for a period of time, and some people do shoot back up. And that's really one thing I've learned to appreciate for HIV. It's just that it's so variable. I mean, even when people are first infected, I'm not sure if you've heard, but there's people called elite controllers who will essentially have undetectable HIV viral loads off medications. And then there's, that's one spectrum. And then there's people that rapidly progress to AIDS once becoming infected. So really a whole spectrum, in terms of disease manifestations, in terms of how people respond. And that's one of the, I think, hallmarks to me of HIV and one of the challenges as well.
I have one question as well. May I ask that?
Yeah, go ahead.
So you talked about being in policy making aspects as you have now transitioned some parts of your job. In terms of creating expert guidelines and policy advice, and as you move forward because of COVID, you are better prepared. But has that ever occurred into the back of your mind that yes, science has progressed, but the policies haven't kept up? And what then?
Yeah, it's a great question. So so in COVID, let me just be honest, no one knows what they're doing. My favorite expression has been, we're building the plane while flying, right? I mean, I've heard that 10 times a day. Like honestly, no one knows what they're doing. And you look at stories like hydroxychloroquine and all this other stuff that's coming out here. I mean, it's we could probably talk 5 hours on that alone. So we're learning, right? And so COVID has been, one of the astounding things about COVID has been the pace of the science that's now out there and how things rapidly adjust and are trying to keep pace with the literature. I mean, it's absolutely mind-boggling and amazing. And it's amazing how people who've never, ever been in infectious diseases are doing COVID research. I mean, you have people coming out of the woodwork. I mean, I've been on conversations with people developing smelling devices to sniff for COVID. There's articles out there about how dogs are sniffing for COVID. There's there's engineering about, some of these great engineering studies, right, showing about the dispersion as someone coughs or sneezes, some really artful stuff. There's structural engineers designing like new, N95 masks and 3D printing. I mean, it's really crazy and amazing and all wonderful all at once. And I'm like, well, if we ever put our mind as a world to some of these other diseases, like we would solve HIV by tomorrow. So, and you look at like, the vaccines, right? It's like, the vaccines, keep in mind, it takes 8 to 10 years to bring a vaccine to market, right? And we're not even a year out of this, and it's already like we're ready to vaccinate. So that kind of makes us all a little bit concerned all at once, but also it's amazing and technology and so and fantastic. So this is hopefully none of us will ever see anything like this again. If we do, we're all going to be much better prepared. I'm not even sure if I answered your question. I kind of went on a random tangent there.
No. Thank you. I appreciate it. And thank you, Dr. Gray, for doing this.
Yeah, thanks, Matt. Talk about that real quick. In terms of curing HIV, one of the students in the comment section asked, like, why have we been able to get a vaccine for COVID so fast, and yet HIV has been around forever, been studied forever, and not forever, but like early 80s, late 70s, etc. Why are we not that close to a vaccine yet for HIV if we're already this close to COVID? And I will put an asterisk on this, that I learned the answer to this on TikTok today.
Better make sure I get it right.
I learned everything on TikTok.
Am I dating myself to say that I don't even really know how to use TikTok?
Oh, TikTok's so amazing. Stay off of it. It's so addicting.
Yeah, so great question. So HIV, there's a couple reasons. You do see, let's step back for 1 second. So when you develop immunity, right, to a virus, it's because your body develops antibodies, right? And so with SARS-CoV-2, you have this one protein called the spike protein, right, which is the main receptor that binds to the ACE2 receptors, which are actually predominantly in the lung. And that, by the way, is actually why you get pneumonia due to SARS-CoV-2, because there's not as much ACE2 receptors up here, but they're more in the lungs, which is why it goes right to the lungs, which is fascinating and terrible all at once. And that spike protein is right on the outside of the coronavirus. With HIV, it's different. And so you actually get antibodies against HIV, but the problem is that they're not the right antibodies. So you get tons of antibodies, but HIV has like a shielding around it, and the exact receptors are actually hidden. So when your body sees HIV, yeah, it's developing all these antibodies, and they basically bounce off or bind to like non-important parts of HIV. But when the virus gets close to the cell, it opens up to expose those receptors that need to bind to CD4 and others to get into the cell. So that's how I explain it to people. I'm not sure, Ryan, if you have anything else to add to that.
Yes, it's like stealth mode in terms of how it works, which is really cool. That and I think another potential addition to that would just be how fast it replicates, and the errors in the replication is the genetics are so different. It's hard to develop a vaccine because it's constantly changing, right?
Yeah, that's a great point. And it's also why resistance develops over time, is because you have, these medications, by the way, nowadays are fantastic, and you kill off 99% of the virus. But if you don't take them all the time and have appropriate drug levels, what happens is you get these suboptimal concentrations. And because of this high error prone reverse transcriptases, to your point, you get these mutations that can escape and overcome the drugs. So, yep, that's a great point.
Yeah. Kayla, any last question from you before I kick you off and we'll get some other students in here?
I just had one more question.
Yep.
What do you see the future after the COVID pandemic, and how that's going to change policies going forward? Like, what are new things that are going to be put into place? Like, do you see people wearing masks more often, or like, do you see us becoming a mask society, like some of the articles are saying, and things like that? Like, what do you think is going to happen with our society and how we plan for pandemics going forward?
Yeah, well, I'm just trying to make it to May here. That's my new rallying cry. Make it to May, and hopefully we'll all be over for Memorial Day. But I think to your point, absolutely. I think that and I think about myself in this situation, right? I'm not sure that I'll be able to fly on a plane again without a mask, or maybe a while.
I might talk.
So I definitely think that certain people will change their behaviors. I think we will see. I think we will see a lot more mask wearing. I think it's going to take us time. I mean, just to be honest, I think that our entire society has, some degree of, trauma, right? I mean, associated with, rightly, understandably, we all have some sort of trauma associated with this pandemic. It's going to take us a while to get over this, I think.
Yeah. In
a lot of ways.
An interesting potential correlation between HIV and COVID, or SARS-CoV-2, is the criminalization around the knowingness of spreading it. A comment came in about your thoughts about the criminalization of spreading HIV to sexual partners when you're known positive and you don't tell your sexual partners. And we've seen the same sort of criminalization around going and coughing on someone right now. What are your thoughts on that sort of criminalization of this pandemic and disease?
So I think there's two slightly nuanced questions here. So take the person that's coughing on the grocery food, right? So that the intent is there to cause harm, obviously, and there's no one else involved in that situation. So that to me, should be criminal, right? If you're intentionally trying to spread an infectious disease. I think with sex, it's a little bit harder for a couple of reasons for me to come to that conclusion. So the first off is it takes two to tango, right? So there's always two people involved or more in sex, usually.
Yep.
So you have to, and the nature of the world, you just can't trust people. So you have to take the appropriate precautions yourself and your sexual partners and ask. And obviously you never potentially really know someone, but you just have to be realistic, unfortunately, in this day and world. And I think certainly when there's intent and malicious of someone trying to spread HIV, and certainly obviously sexual assault, those things need to be criminalized.
Yeah.
But the other thing too, I'd like to think is that, as human beings, we all have some desire to do good in the world. And what a lot of us in public health worry about is that if you criminalize HIV transmission, people will stop telling you about their partners, and it's going to harm this process of contact tracing, et cetera. So I understand why some people may think about criminalizing HIV, but at the end of the day, it is really, I think, counterproductive, and people do have to just be careful in general.
Yeah, it's a similar kind of psychology around why we're trying to decriminalize marijuana right now. Oregon just decriminalizing all drugs is really removing the stigma and getting people the help they need versus putting them back in the closet, so to speak, right? Let's go. We have Margaret and Joseph here. You have any questions? Or Dr. Chan, you have a case that we can throw at them, make them sweat a little bit?
Uh-oh, on the spot. Well, let me ask you if you have any questions first before I give you some questions.
Oh yeah, can I ask a question? Can you hear me? I can't.
Yep.
Okay.
That sounds great.
My name's Maisie. It's Margaret, but Maisie.
Maisie.
But my question was, in terms of vaccine hesitancy, especially surrounding, in general, there are a lot of people that are vaccine hesitant, it seems like, in certain areas, but with COVID-19 and the vaccines, I just feel like I've been hearing more and more people say, oh, I won't, ever get any sort of vaccine that the government has made in less than a year, or, yada, yada, yada. Warp speed is a terrible name. And then I've also seen some stuff about the possibility that we'll have to have some sort of card in our passport if we're traveling that says we've been vaccinated, which, what are your thoughts on how vaccine hesitancy can be handled, or the best approach?
Yeah, so I think the way I look at this is that it's understandable, right? I'm going to get the vaccine. I'll just throw that out there. But totally, right? I mean, we've gone through this process really quickly. It's been less than a year. mRNA vaccines are not widely used. There's like one other one for Ebola that's out there. So yeah, it's understandable. So the conclusion, though, is that you have to look at, you got to look at pros and cons of all this. And so the pro of getting the vaccine, I mean, do we all want to live like this for another 10 years? I mean, of course not. No. So let's get the vaccine. I think it's a no-brainer for some people who are older, right, and have comorbidities. Like if you look at the older ages, right, for COVID-19, I mean, if you're over, 60, 70, you have like over a 10% chance of dying. So that to me is no-brainer. You get the vaccine, right? For us younger, and I guess I'm calling myself younger. I don't know how old you are, Ryan, but I'm 42. So
I'm 40.
You're 40. Well, so we're youngish. We, from a public health standpoint, we just got to do it, right? I mean, they've vaccinated tens of thousands of people. People are doing fine. Is there a risk of a longer-term side effect? There is. There is. And we just have to be comfortable with that and understand that we have a lot of history with other vaccines and that people generally do well. And that this is just important to get over because we cannot go back to normal until people get vaccinated. And it's also a case of like, you may not do it for yourself, but are you going to do it for your mom, your dad, your grandma, your grandpa, et cetera? So, to me, I'm going to get it. Am I a little bit nervous? Yeah, I am. But I think it's important to acknowledge that. And I think we'll know more certainly as time moves on here, but I would get it. And I would just keep in mind, there's a front page story in my local newspaper today about a 30-something-year-old anesthesiologist who had no past medical history, who ran every single day, and he was in the hospital for a week or more and almost died, right? So this is kicking the butt of normal, otherwise healthy people. And by the way, I'm totally otherwise healthy. I don't take any medications. I don't visit the primary care doctor as often as I should. Et cetera. So, and I run every day, but I'm still going to get it because I'm nervous, and also for the good of public health. So,
talk about for a second, Dr. Chan. You mentioned earlier about how we're building a plane on the way down. That seems to potentially have
on the way up.
No, you're building it on the way down, hopefully finishing it so it can go up. It seems to be that with science so public right now, in a time where it's needed right now, it seems to be causing a negative effect with more distrust of the scientific community because it seems like people are changing their mind every 2 seconds. And we have Dr. Fauci at the beginning saying, don't wear masks. And we know why he said that, but now he's obviously saying wear a mask. And the hydroxychloroquine, is it good? Is it bad? And we have all this stuff happening just in the public, which is normal science, right? You and I and everyone else here who are scientists, we understand that we have a hypothesis, we test it, we got it right, we send it to someone else, they test it, it didn't work, we retest it, what happened, what went wrong, right? That's science, and the public sees it as we're a bunch of buffoons that don't know what we're doing. How do we overcome that perception?
It's a fantastic question, and one of the biggest things that I've learned about in my role in public health is the importance of communication and messaging. So my first day in response to the COVID pandemic, we set up an incident command structure, right? We have 50 of the top people in our state, public health, who come into this room and decide what to do. And I'm sitting there and there's this whole communications team. And I'm like, what are they doing here? I'm like, get the doctors and the scientists here. And that was literally my thought. And hopefully they're not listening. But since that time, I've come to appreciate it. And I've learned over time that half of it, more than half of it, is just communications and messaging to people. And I've really gained an appreciation for that. And I think to me, the saddest thing, we're trying to stay away from politics, but the saddest thing about where our society is heading is this whole movement about misinformation and fake news. And because it's being applied to science. And I don't understand it, to be honest. It's at the end of the day, if you can't rely on facts and science, where are we, right? It's what are we doing? And so that, to me, as a society as a whole, is really, really undermines us as scientists, as physicians, as public health, and it's not what we're known for from the United States of America. Like we have to do better, and I'm guessing that a lot of you are listening because you want to do better. And I would just encourage you. I have found my voice in public health, and it's one of those areas I think for physicians to be able to have a voice that can be heard and have it heard across government. So I think I struggled a lot of times as an individual clinician, and I love being a seeing patients, et cetera. But it wasn't until I got involved in public health that I found like my voice was suddenly heard across multiple sectors of society, including government. And I've interacted with with casinos and like gym owners, et cetera. So they're listening, and I love it. So I'd encourage more physicians to look into public health. It really can be rewarding.
Yeah, the public health world, preventive medicine. I had a preventive medicine specialist on. They definitely interact with the population at large and government. So that's great. Joseph, you're on here. What questions do you have?
Hey, so I have 2 questions.
Yep.
So first, I was going to say herd immunity. People are going to get the vaccine, and then schools. We're talking about schools opening back up, and we want to see people getting the education that we previously had and everything. How is this going to work? Especially for people. I was also my second question adds to this, for people in like the lower communities, the poverty communities, and people that don't have
lower socioeconomic.
People that don't have the
means,
economics, I guess.
Yeah, so it's a great question. So I think even just take a half step back, I think one thing that became apparent in April and May is this concept of disparities in COVID during the pandemic. And everyone's looking around like why are there disparities in COVID-19? And for those of us that have worked in the field of HIV, we're like, no, duh, who do you think that this is going to affect, right? But if you look at it, like it surprised people in the US, and all of a sudden there's like these huge front page articles about, African American, Black, Hispanic, Latinx, urban settings, lower socioeconomic, and, dense housing structure units, et cetera. And it's like, duh. But it is what it is. And I think it shows that we need to do more. And what we're doing, at least in our state, is we're having one of our first vaccine rollouts and campaigns is, to your point, in a dense urban setting with of lower socioeconomic status. So you have to be proactive, you have to be engaging, and you got to go to these places. You can't like set up something in suburban white America and expect people to come to you. You need to set it up and go to them. And you need to have culturally competent, including languages, right? You need to have materials in Spanish and whatever other, local languages may be pervasive in the community, et cetera. And you have to engage community. And that's another thing that I love about public health is it's not just public health, it's also community medicine, because you got to get out there and learn about the community and make a difference. So that's a fantastic point, and totally agree. And, we still haven't learned how to do it.
And then quickly about the herd immunity with like schooling, I guess. Like when people get the vaccine, you see lots of others might not need to get the vaccine, I guess, in a sense.
Yeah, so we think herd immunity will take effect with SARS-CoV-2 when at the very least 50 to 60% of the population has developed some degree of immunity. So, 1 out of 2-ish at the absolute minimum. So you're right. I mean, technically it can happen, but it does revolve. If everyone had the attitude that I'm going to rely on herd immunity, then it wouldn't work. So I think, especially as healthcare professionals and role models for society, is that we should do our part at least to get vaccinated. And keep in mind, healthcare workers are most at risk. So again, I know in general, younger people tend to have more mild illness, but people are dying.
Yes.
Thanks, Joseph.
Thank you, guys.
A good question that came up. We talked about misinformation and kind of the distrust of science in the general population now that seems to be growing among the anti-vax community, et cetera. But we also have communities who have a very good reason to distrust science. And those are the communities where we have syphilis experiments and doctors operating on people without their consent because they're from disadvantaged backgrounds and they could do what they wanted. And obviously, we think of those times as being a long time ago, but they're really not. How do we reach those communities and really prove to them that this is real and we're there for them and not just trying to take advantage of them?
Yeah, so that's a great question, and I think it involves with getting out there and educating and meeting people where they're at. I mean, these trust issues run deep, and it's not their fault. I mean, to your point, I mean, we in general as a medical community have done terrible things to people in the past, and of course, not me personally, but we live with that legacy. And so, to your point, we gotta build the trust. And it starts by listening to people. It starts by getting out into the community, meeting people, and it's one little step at a time, right? We can't expect things to change overnight. And so what we're seeing with COVID is a reflection of medical distrust overall. And this is a huge issue. It's a major structural barrier to everything from HIV care to colonoscopies to vaccines in general, et cetera. And it's a big problem. And we have to figure out how to do better.
Yeah. Well, Dr. Chan, I will end the conversation there. Thank you so much for having a good COVID talk with us, since that's what we're all about. We got a little HIV STI in there as well, though.
Great. Thank you for having me.
Yeah. Everyone, thanks for showing up. We'll have the quiz and replay up soon. Everyone have a great night.